Hello, everyone. Welcome back to another episode of the Tokyo Living Podcast, Injury Edition. Today, we're going to be talking about frozen shoulder. Now, this is a common condition that we see quite frequently in the clinic. However, there is a little bit of, misunderstanding about some of the traits of a frozen shoulder, how it differs from other shoulder conditions, how we go about diagnosing it, perhaps some of the other diagnostic labels that are used to describe this type of pain, and also the way that we go about treating. So frozen shoulder is something that affects people primarily in the sixth decade of life, so between 50s and 60s. This is why in Japan it's known as Gojikata, and it has a similar sort of label in Korea and China. Clinically, we tend to see it more in the first half of the sixth decade, and I tend to see it, I get a lot of people that are coming in between 51 and 53 with this condition. But as far as a textbook description of the condition, we usually see it's between 50 and 60. It is thought to affect women more than men. However, that's being questioned in recent years as well. And for whatever reason, we do see it more on the left side rather than the right. So what's actually happening in a frozen shoulder? We're basically getting a contracture, almost like a shrinking of the shoulder capsule. So the shoulder capsule, like the term capsule suggests, like a capsule hotel, for example, something that I've actually never experienced despite being here in Japan for 18 years. Essentially, capsule is something that surrounds something else. And essentially that's what the shoulder capsule does. Our shoulder joint is inherently a relatively unstable joint. It's a big ball on a small socket. So we need all these other sort of constraints to provide us the stability that's required to carry out the large degrees of freedom that our shoulder allows us that other primates don't have. Part of this shoulder capsule is made up of active structures. So our musculotendinous units, the tendons of our rotator cuff muscles sort of blend into that capsule. So it does have a contractile element to it, but it also has ligaments that are blended in. And those ligaments provide support and structure and stability within certain movements of the shoulder by attaching certain parts of the top of the arm to certain parts of we call the glenoid, the bit of the shoulder blade that basically articulates with the arm to form the shoulder. Then we also have this non-specific collagen, this other substance that surrounds, it sort of fills in those gaps between tendons and ligaments, and helps create this capsule. In the case of a frozen shoulder, that starts to tighten up. And as a result, we get a decrease in the volume of the joint fluid. So that normal lubricant that we have there in our joints starts to decrease, and everything starts to get a little bit stiffer. And this is associated with an inflammatory process. So we get changes in the immune and inflammatory markers around the region. And we also get an increase in contractile proteins. And so that all starts to create this painful condition. Now, in some people, this comes on secondary to some sort of trauma. So we might have an injury or an incident that actually sparks this inflammatory cascade that then leads to the frozen shoulder. That might happen in maybe 5 up to 10% of cases, but the majority of the cases of frozen shoulder, it usually comes on for no reason. So we get to a certain age where perhaps we're prone to those inflammatory changes, and something just triggers this change in the shoulder, and we start to get this tightening. And it will usually come on gradually. So someone might report a little bit of stiffness, a little bit of tightness, then something that might, it feels a little bit odd. I might just try and stretch that out, and over the course of several weeks, it starts to get worse. And our sleep starts to be affected. We start to get night pain. And this is a hallmark signature feature of our frozen shoulder. And so this is when we're going through someone who presents with shoulder pain, these are the key things that we're trying to figure out to help us make our working diagnosis. So if it's a gradual onset with no real cause, and we're starting to get night pain, then that's starting to guide us down the path of looking at frozen shoulder as a diagnosis, and particularly if someone sort of meets that age range. Someone comes in their 20s and 30s and they report shoulder pain, we're not really thinking of that. It can happen, but it's very, very rare, and it's not the sort of the first thing that we think of. Now, in terms of differential diagnosis with the frozen shoulder, the most common local shoulder issue that we would be differentiating from would be a rotator cuff related shoulder pain. Now, this sort of that broad spectrum of diagnosis includes things like a rotator cuff tear, a partial tear or full thickness tear, through to a rotator cuff tendinopathy, or might be called a tendinitis, which I will cover in a future episode of the podcast. But generally with those sort of conditions, we note that there's some sort of change that happens prior to them coming on. So someone the typical example of a rotator cuff related shoulder pain is someone goes out and they paint their house, and they're not used to painting the house. So they're doing a lot of shoulder movement that is unaccustomed for them, and they start to develop pain, or they might increase their exercise or general activity regime, either systemically or something that directly affects the shoulder, or they might include different exercises within their exercise program, and that starts to cause pain. So there's usually some sort of change. Or if someone's playing sport, they might use a heavier racket, or they might be playing tennis in the rain, for example. Different equipment changes, ergonomic changes, all those little things that can change load. And if you're not familiar with how I discuss load, please go back and listen to episode 1, because that sort of sets the framework of how we look at injuries and how we look at injury management. So there's usually going to be some sort of change in load with the rotator cuff related shoulder pain. And that's not so common with the frozen shoulder. Also with the sleeping and the night pain, generally with a rotator cuff issue, it will be a lot more painful when someone is lying on the affected side. So if I have a rotator cuff issue on the left side and I'm lying on the left, it will be painful. But if I can get in a position lying on my right, maybe supporting the left side, it's not going to be as bad. Frozen shoulder, it's a little bit different. It will tend to be painful regardless of what position we're in. So when we fall asleep, we get changes. Our immune system starts to slow down. And because of that change in the immune environment around the shoulder, it will start to then complain and start to be more sensitive. Now, I'm just going to briefly touch on some of the other terms that are used for frozen shoulder. Now, this condition has been described since 1896. By several authors, and as we've gone through the journey of understanding this condition, the name that's used to describe it has changed as well. So originally in 1896, Duplay referred to this as a periarthrite scapulo-humorale. The French doctor, I'm sure I'm pronouncing that incorrectly, but he basically attributed this to inflammation of the what we call the subacromial bursa, so the fat sac that sits underneath the articulation between the collarbone and shoulder blade. And that was used for a little bit. The biggest change, where the first person to describe frozen shoulder was a surgeon named Codman in 1934. Now, he had also previously described this as adhesive capsulitis about 10 years earlier. And he thought at the time that it was actually parts of the shoulder capsule that were sticking, that adhering to the top of the arm. But then he later found that by operating on patients that he didn't find those adhesions. So he then started rejecting that terminology and started to refer to it as frozen shoulder. Then we had Littman in 1934, who felt that it was more an issue of the biceps. So the biceps, everyone knows how big the muscles that you flex to show how muscular you are. That actually attaches up into the shoulder, and it's one of our major shoulder stabilizing muscles. And he felt that it was more an issue of the biceps that was causing the pain. And then we had Navasia in 1945, who came back and went again to this adhesive capsulitis narrative, again arguing that the pain was due to adhesions, similar to like a plaster, as you sort of apply plaster to a structure, that sort of adhesion that was causing that sort of stiffness within the shoulder. However, Lundberg, Bunker, and others since then have looked into this, and many other surgeons and researchers have looked into this and not found these adhesions present. And so we've gone back to now using the term frozen shoulder, or in 2016, Jeremy Lewis proposed the frozen shoulder contracture syndrome, focusing on the contracture and the shortening of the shoulder capsule. I personally don't like the term adhesive capsulitis. One, because it doesn't sort of fit with pathophysiologically what we know about the condition. And it also may conjure up some images within the patient of something being stuck within the shoulder, and that may prevent them from being active within a rehabilitation program, and decrease their movement due to fear of movement and things like that, which is not what we want. whilst I'm a big fan of Jeremy Lewis's work and sort of consider him a mentor, I also don't like the term syndrome when we can avoid it. So for me, I like to stick with the term frozen shoulder, and then from there go into an explanation to the patient about what this actually means. Um, so when we go back to the onset, frozen shoulder is one of stiffness being one of the predominant factors. So with rotator cuff related shoulder pain, you might have full range of motion. You may be able to sort of get to the ends of your range, but you might have a catch of pain during the middle of that, especially if it's more on the tendinopathy end of the continuum as opposed to a full thickness or partial thickness tear, where weakness is not so much a problem. We may still have full range of motion. We may just have a little bit of soreness through that range. With a frozen shoulder, it's stiffness. We can only lift it up so far, and the further we lift up, the stiffer and more painful it becomes. Within the progression of frozen shoulder, we usually go through phases. Now, there have been sort of between 2 and 4 phases described for this. And for a long time, we sort of worked within these 3 phases of a freezing, frozen, and thawing phase. Freezing, obviously, things are getting stiffer. Frozen, things are frozen, they're stiff. And then thawing, it's thawing out and starts to get stiff. You lose some of that stiffness and start to regain your mobility and function. More recent times, though, we've found it easier from a treatment perspective to put things basically in 2 categories, pain and stiffness more than pain. So we start off with pain being more of a predominant factor, and then as the pain decreases, we're left with more of this stiffness. And the way that we manage the condition in those phases, and it's not like you tick over a certain phase and then you're done, you're into the next stage. It does happen progressively, but it does sort of guide us in terms of our treatment. Diagnosis-wise, frozen shoulder is very easy to diagnose, which is why, for me, I find it a little frustrating when the misdiagnosis of this condition is being made. With a rotator cuff-related shoulder pain, you'll generally have pain on active movement and resisted contraction. But when you're, especially if the patient isn't too irritable and it's not too severe, we can generally take the patient through a full range of motion without any pain, or with minimal symptoms, and certainly no restriction in range. Whereas a frozen shoulder, the passive range and active range will be the same. It'll be equally restricted. And in frozen shoulder, we need to make a definitive diagnosis of frozen shoulder. We need a restriction in external rotation. So if you're watching the video version of this is where you're basically arms by the side and you're rotating outwards, or arms up here and rotating outwards. There's different degrees and different positions. We can test external rotation, but there will be a restriction, and typically this will be at least 50% by the time we're actually giving the patient a diagnostic label of frozen shoulder. Imaging within frozen shoulder is generally not required in terms of like MRI and ultrasound. People will often get sent for an MRI and will come back with findings of things like a fibrosis of the rotator interval. Now, that does happen in frozen shoulder, but it does happen with other conditions as well. So that's not particularly helpful from a diagnostic perspective. And sometimes we might have a patient who has clinically signs of other conditions, such as a rotator cuff related shoulder pain, but they have this fibrosis of rotator interval come up on the scan, and then that might guide the practitioner into managing it as a frozen shoulder, which has a different sort of management, a course of management. However, X-ray is important. So very, 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 very occasionally, and it's not something I've seen within my career, but sometimes we might have some nasty non-musculoskeletal conditions that masquerade. So we can have a tumor in the top of the arm. We can have what's called avascular necrosis, where basically the top of the arm starts to rot. And these are horrible conditions and obviously life-threatening. So if someone is reporting frozen shoulder like symptoms, I always make them get an X-ray just to rule out these nasty other conditions that might be masquerading. But apart from that, that's what we really need as a diagnosis. So in the early stages, this may present similarly to a rotator cuff related shoulder pain. So that's why we're on the fence with the diagnosis early on. I'll usually go about treating in whatever working diagnosis I have at the time, but then I'll constantly monitor symptoms. And if someone is starting to lose external rotation range of motion despite going through our normal management, and I actually had this presentation 2 days ago with someone who we thought had a rotator cuff related shoulder pain. They had an acute onset of their pain and they didn't have restriction in range of motion, we started treating, and over time, the external rotation range of motion started to decrease and decrease, to the point where now I'm confident that this person does have a frozen shoulder, and that does sort of change our management plan. In terms of treatment of frozen shoulder, so early on, we want to try to manage pain. So it used to be the case where we tried to stretch through these conditions, and later on, that might be a strategy that we could employ. But early on, stretching will tend to make things worse. So if we've got a frozen shoulder, it's early in the diagnosis, or it's early in the stage of the condition, we don't want to be stretching, because that is going to increase pain levels. Now, it's important to note that it might increase pain levels, but not really going to increase, it's not going to worsen the condition. And that's something that I want to educate patients with early on, is that, you're safe to move. If you get a bit of pain, it's going to be a bit sore. It might be a bit irritable afterwards, but you're not making things worse. So we don't want to install a fear of movement, but we do want to install a healthy avoidance of painful movement, just so that the person's not experiencing excessive amounts of pain. We're understanding now that early on in a frozen shoulder, in the painful stage, a corticosteroid injection, or up to 3 corticosteroid injections, possibly in different sites, so both the actual joint capsule in the center of the joint, and also in that area that I discussed earlier, the subacromial region under that area where the shoulder blade and collarbone meet. Steroid injection in that area, very effective in settling down pain and also decreasing the contractile proteins that I referred to before. So you've got these substances around the shoulder that are basically hunting in on that capsule and trying to get it to tighten up. And the steroid injection can actually make a big change to the number of contractile proteins in the area and really put the brakes on the progression of the condition. Not resolve it completely, but can make a big difference and can decrease the length of time that it takes to recover. In the literature, and this is fairly scary for those people going through the condition, but the average time to recovery for a frozen shoulder is actually 2.5 years. So anything that we can do to shorten that process is obviously going to be advantageous. So if someone understands the risks associated with an injection, and is comfortable with the slight discomfort that occurs at the time, then it's something that I do encourage. It's not something that I encourage for a lot of conditions. I'm not a big fan of injections as a whole. We have got to Ask 360 episode on injections a little while ago if you want to hear a little bit more of a broader sort of overview on injections. But for this stage in frozen shoulder, it can be very effective. From there, like I said, education is a big piece. We want to get the shoulder moving, but we don't want to push it to end of range. So we'll get people generally doing gentle sort of active movements within their available range of motion, and then progress to doing some strength work through that side. Because we do want to try and maintain strength as much as possible. So as we come out of the frozen shoulder and we're regaining our range of motion, we are able to rehabilitate the strength and the function quicker than if we essentially ignored pain in the area. As we get basically stability in the condition so that the stiffness isn't worsening, we can start to implement some very gentle range of motion exercises, starting to push into range, but starting to use techniques where we can decrease the amount of muscle guarding. There's a study a few years ago out of Canberra where patients were basically put under general anesthetic, so they're put to sleep, frozen shoulder patients, and they had their range of motion tested, and in all cases, it was actually a lot better when they were asleep. So even though there's a structural thickening and tightening of the capsule, there's also a cognitive component, a muscle guarding component that our body knows that something's going to be painful, so it will put the brakes on it and basically protect us from moving through that range. So we have some strategies in terms of exercise and manual therapy techniques that we can use to try and unlock some of that movement and decrease some of that muscle guarding. And that's generally where we start, rather than just pushing into resistance, whether that be structural resistance or muscle guarding resistance that's likely to make things worse in terms of pain. We tend to try and work on techniques that will allow relaxation of the muscles and allow us to get further through range. We also want to continue our general exercise. So as we talked about before in the load episode, general exercise is key to decreasing the sensitivity associated with pain. So we want to keep people as active as possible in terms of general exercise, and then also training the non-affected side. So by training, if I've got a frozen shoulder on my left-hand side, we want to do strength training on the right-hand side to maintain strength on the left. And again, we have an Ask 360 episode on cross education, training the non-affected side to gain function and strength on the opposite side. But also we have an inhibition, a pain inhibition mechanism where if we train one side, we can get some decreases in the pain on the other side through cortical processes. So definitely focusing on general activity, focusing as always on doing everything that we can rather than focusing on the things that we can't do. As things start to improve, so especially as sleep starts to improve, and hopefully that's earlier rather than later, if we've gone through that process of administering the corticosteroid injection, we can start to push our range of motion a little. So as we're dealing with more stiffness rather than pain, we might push into a little bit more of that resistance. Where possible, we still use techniques that elicit a decrease in muscular guarding to achieve that change in range of motion, but we can start to push a little bit more because generally at that stage, the patient will have less irritability, less pain after exercise and things like that. If we get into the stiffness phase and things really aren't changing, then another injection procedure we might want to consider at that stage is what we call a hydrodilatation or a hydrodistension, where we're basically injecting saline into the joint, but we're injecting enough that we're almost sort of stretching things out. And then if things still aren't improving, there are some surgical options, such as a surgical debridement of the cuff, or what we call a manipulation under anesthetic, where put you to sleep and we crank it back. Now, all those three things, so hydrodistension, some positive results there. With the surgical procedures, really not that effective. And in our experience, we haven't had a patient that's needed to go down that route. But occasionally someone might be very impatient with the length of time that it does take to get better and is willing to take the risks associated with surgery, in that it might make things actually worse if we go down that route, but that if the patient's at a risk, that's a risk that they're willing to take, then that's something that we can go through with the patient at that stage. Now, one other thing in relation to frozen shoulder, whilst most cases in my career and what we've seen in the literature have sort of been individuals in that sort of 50 to 60 age range, we have seen in recent times some younger patients come in with this condition. And it has actually been brought on by the COVID-19 vaccination. Now, because most people have had several vaccinations and they're not sort of going through the vaccination process now, we're not seeing it as much, but sort of 6 to 12 months ago, we were seeing a lot of frozen shoulders that came in on within a week to a month after administration of vaccination. Now, we do have this condition called, it's known by the acronym SIRVA, so shoulder injury related to vaccine administration. And this was first described in the research in 2010. But obviously, in the last sort of year or two, we've had a lot more people getting vaccinated and a lot more people being vaccinated by people that don't usually do vaccinations. And as a result, there has been some issues with vaccination technique where they've injected basically too high up on the shoulder rather than the belly of the deltoid muscle. They've gone too high and actually pierced the subacromial bursa, which is then, and the subdeltoid bursa, which has then caused an inflammatory cascade, which has then led to a frozen shoulder. So this is something to look out for if you have had a vaccination. It's still relatively rare for the number of people that are getting vaccinated or have been vaccinated over the last 18 months. But if you have had a vaccination and you've had shoulder pain come on after that, then you might want to look into frozen shoulder as a potential diagnosis. If you do have any follow-up questions related to frozen shoulder, please send them through. And as always, if you are experiencing symptoms, if you're in the Tokyo region, come and see us. If you're not, go and see an experienced medical practitioner. And if you're not sure, if you're in an area where you don't have access to, or you're not aware of where to go, we may have some contacts in your area. So please reach out. So thank you very much for listening. If you do have other musculoskeletal conditions or topics that you would like me to speak on, please send them through and I'll do my best to keep providing some useful information to you guys. Look forward to seeing you on the next episode. Take care.